So this is like an impromptu video. It's gonna look a little shitty, and I got papers and shit that I'm gonna refer to throughout the video as we go on because I can't remember everything. But my goal is to just kind of help you be able to interpret an ECG, not just be able to look at it and memorize what it's supposed to look like, but actually systematically go through whatever kind of strip you're looking at and understand what you're seeing, why it looks like the way it looks, and what does that mean. So you should be able to understand why things look the way they do. What does that mean in terms of what's happening in the heart in your patient, for all different types of arrhythmias. Before we get into looking at arrhythmias or even how the different rules, we should refresh on conduction and how that happens in the heart. So I'm just going to draw our right and our left atria. So we got our two atria. You could imagine this as our interventricular septum. So up at the top of the right atrium, we have the SA node, the sinoatrial node. It is the commander, okay? In a normal heart rate, it is setting the beat without any sort of external innervation, without the sympathetic or parasympathetic nervous system. It fires and sets a normal beat of 60 to 100 beats per minute. All right, so we have the SA node. We have another node right down here at the bottom of the right atria in the interventricular septum. That's the AV node. So in the SA node, we have the AV node. Between those two, there are conductive pathways that are going to bring the impulse through the atria into the AV node. They also go out to the left atrium in order to depolarize that at the same time as the right atrium. From the AV node, you have a structure called the bundle of His. And the bundle of His is going to take that impulse down to the interventricular septum, just a septal wall of tissue between the right and left ventricle, and it is going to branch into the right bundle branch and the left bundle branch. And then those are going to wrap around the apex of the heart, the bottom of the heart, and then come back up. And then the left ventricle, the left bundle branch does the same thing. There's also another bifurcation, another branch, but don't worry about that. So the signal, and then it goes into the tissue, or really through the Purkinje fibers. I'm not gonna write that down, I don't even know how to spell that shit. So the impulse starts in the SA node. In a normal heart, that's where it starts. Okay, when the SA node fires, it goes through the atria, through the right and left atria, but all coming back into the AV node. And then the AV node, from there, it's going to go through the bundle of His, and then it's going to go bifurcate down the right bundle branch, and then through the right ventricle, and then the left bundle branch through the left ventricle. So SA node sets the normal pace, 60 to 100 beats per minute. The AV node, if it is in control, if the SA node is damaged, dysfunctional, the AV node has an intrinsic heart rate of 40 to 60. So if the SA node is knocked out, the AV node takes over, but it's slower. It's got, for multiple different reasons, the action potential, the impulse, it takes longer to get through the AV node and then through the ventricles. So you have a 40 to 60 beat per minute. If the SA and the AV node are knocked out, the ventricles can actually create their own intrinsic heartbeat in pacemaker cells in the Purkinje fibers. But it's not very fast. It's something around 20 to 30 beats per minute. But that's very important once we get into certain arrhythmias. So again, normally, SA node fires, spreads through the atria, they contract. Meanwhile, the AV node holds on to that impulse for about 0.1 seconds. And that's important because it allows the atria to actually contract and push out the remaining blood into the ventricles, called the atrial kick. The AV node then releases the impulse down through the bundle of His, through the bundle branches. It starts depolarizing the ventricles starting at the apex and then up towards the base of the heart, which is the top of the ventricles. Ventricles contract, push blood out of the heart. They relax, and it restarts again. So when you're looking at a 12-lead ECG, or even a 5-lead, but we're going to be talking about a 12-lead here, you are actually using 10 electrodes that are placed at different areas of the body, and it's not important for right now, I'm not really going to focus on that, but 10 electrodes create 12 leads. A lead is just a viewpoint of the heart. In other words, it is a unique angle in which the machine is viewing changes in electrical activity, changes in voltage in the heart through the skin. So each lead is getting a different view. So just to kind of draw that out quickly, let's say we're looking at a torso, right? And sternal notch up here. And this is the heart. It's not perfect, but. So this is the heart right here. So you have this is the right side of the body. This is the left. 10 leads. Right arm, right leg. Right leg is a grounding lead. It's not used for making electrode. Right arm electrode, right leg electrode. This one's really not important. It's a grounding electrode just to get rid of any sort of artifact from movement in the body if they're adjusting or whatever. So I'm just going to erase it for our, or I'm just going to put an X over it for our sake. It does not contribute to making 12 leads. So the 12 leads actually come from 9 electrodes. We have a left arm, left leg electrode. Those are so we have 3 electrodes called limb electrodes that actually contribute to our 12 leads. And then we have ventricular or precordial or chest electrodes. So we have V1, V2, V3, V4, V5, and V6. They're not perfect, but the point is that these are our electrodes and they create different leads. They each look at the heart at different viewing points. And so on our ECG, you're seeing a different picture in each lead because you are viewing the movement of electrical activity, the movement or change in voltage in the heart from different angles. So for most floors, like unless you're in the ICU and they specifically have a 12 ECG ordered, you're usually just gonna have on the monitor, the one that they will keep on that is lead 2. Why is that? So lead 2 takes this electrode, the left leg, and it's gonna set it to positive. So this is positive, and then it's gonna take the right arm, and it's going to set it to negative. So this positive electrode is the is the viewing angle. It's where your face is. Imagine you are standing right here looking at the heart. You're basically looking at the apex, straight through the center of the heart, up to the right arm. This one that's set to negative is your reference point. So the machine takes this positive and this negative, and all it's doing is measuring the change in voltage in the heart due to action potentials and impulses that are a depolarization and repolarization. And it's just measuring the movement between this negative reference and this positive viewing point. So this is lead 2. If you look at, so lead 2 is the most often used because you get this incredible view of the SA node up here, firing, sending signals through the atria, causing them to contract, getting to the AV node right here. That is then sending signals down and around, and then back up towards the top of the ventricles, right? This is looking at it like this. It's getting an amazing view, especially of what's going on in the atria, in terms of the depolarization wave that's moving from the top right of your heart, of your atria, to the bottom of your atria, and then to the bottom of the heart and back up to the center. That's why lead 2 is used. And that's where we're going to be looking at for all of our rhythm strips. We're going to be looking through lead 2. So just to give you an idea of what that means when we're talking about lead 2 and what it's viewing, or its viewing angle of the electrical activity in the heart. Okay. So let's go through normal sinus rhythm in lead 2. And let's talk about how we systematically look at an ECG, what the different waves mean, and how that corresponds to what's going on in the heart, so then we can start to understand what abnormal heart activity looks like. And then we can understand, based on what we're seeing, what's going on in the heart. So let's draw another heart right here. And then we'll do normal sinus rhythm. So this is what a ECG waveform will look like for normal sinus rhythm in the heart. If we start right here, let's just put the SA node here. Okay, so on the ECG, this picture is going to be, there's going to be boxes underneath it, and I can talk about what those mean later when we get on to our rhythm strips. But for now, we're just going to go through the waves. This first wave here, that's the P wave. So what's happening is our SA node is firing. So our SA node fires. It depolarizes, and that depolarization, that action potential, propagates through all of the tissue in the atria, causing them all to depolarize. They contract. So what does that look like? So signals start right here in the SA node, and they're sent all through the atria. And again, we're looking at through lead 2. Remember, our viewing point is here, reference is here. So our view of the electrical activity is kind of like that. It's not perfect, but that's our viewpoint. So in lead 2, this is what normal sinus rhythm is. This first wave, SA node fires, sends action potentials through the atria, they depolarize. So all these cells before this were negative. That depolarization causes them to become positive. So we have a positive charge spreading this way. It wouldn't help if I did this. Lead 2, positive electrode, negative electrode, viewing angle, reference point. We're looking this way. That creates our lead. That creates our picture. So looking from here, we're looking up this way, and we are seeing all this positive charge moving towards us as the atria depolarize. So on our ECG, positive charge moving towards our positive electrode, towards our viewing point of the lead 2, creates an upward deflection. So this is the P wave. It represents atrial depolarization. In lead 2, in a normal sinus rhythm, that should be positive because it's starting from the SA node, and that positive wave, if you will, of charge is going from the top right down towards the AV node, down towards the bottom left. Okay, so we have positive to positive going towards our positive viewing angle. And so we get an upward deflection representing the atria fully depolarizing. Okay, then we have this segment right here. So between the P wave and this waveform, we have a line. We have a return to what's called the isoelectric line or baseline, meaning there's no change in electrical activity at this point. It's called the PQ segment. So our atria have depolarized. They are currently all positive. All the cells in the atria are positive. The ventricles, and all this charge has reached our AV node. But our AV node holds on to that charge before sending it down to the ventricles. So again, SA node fired, atria became super positive. They were all negative. This wave of positive washed over them, depolarizing them. And we saw that as a positive deflection called the P wave. Then it all reached the AV node. And so that action potential, that impulse, that positive impulse is sitting in the AV node. And the AV node holds on for it for about 0.1 seconds before allowing it to go down to the ventricles. But before then, there is no change in electrical activity in the heart, because that's all that an ECG measures, is change in electrical activity, change in voltage. So right now everything is positive up here. The AV node is positive and the ventricles are all negative. And for 0.1 seconds, that stays constant. And so we have no change right here. It stays at the isoelectric or baseline. The AV node holds on to that charge for about 0.1 seconds to allow the atria to actually contract and push out the remaining blood that's sitting in them from diastole. It's called atrial kick. It's really important so that all the blood actually gets into the ventricles. So PQ segment. Atria depolarized, causing this wave of positive, making our positive deflection of P wave. It's now all positive in the atria, all negative in the ventricles. AV node is holding on to our impulse. It's not allowing it to go down to the ventricles, causing this baseline called the PQ segment. Next, I'm going to just erase this right here. We have this little downward deflection. As a whole, the QRS complex as a whole, the QRS complex represents this charge, this impulse, this action potential, whatever you want to call it, leaving the AV node, traveling down the right and left bundle branch, then going around and back up like this. What that does is, remember our positive viewing angle, we have this giant wave of positive. The ventricles are big, much bigger than the atria. There's a lot more tissue, so they have more tissue for charge to be conducted through. That's why this is so much taller and has a higher amplitude than our atrial depolarization, because there's so much more tissue that's changing from negative to positive. So the QRS complex as a whole, when looking in lead 2, from positive, looking up like this, we see this giant wave of positive charge moving down and then around, causing the ventricles to depolarize in this manner and then contract. This giant upward waveform, upward deflection, represents that positive moving down towards our positive viewing point, positive to positive, upward deflection. We're not going to worry about the Q and the S wave, just looking at the QRS complex as a whole. Then, after the QRS complex, the ventricles are depolarized. The atria have already repolarized. They went from being positive back to negative in all the cells. That happened during our QRS complex, but it does not create a strong enough amplitude compared to how much electrical activity we see during this depolarization. That atrial repolarization is hidden in the QRS complex, so you do not see it. So at this point, right here, atria are negative, they have repolarized. Ventricles are positive because they're depolarized, they are contracting. We're back to the isoelectric line. We are not seeing any change in electrical activity in the heart at this point, and so nothing is going upward or downward on our picture. It's called the ST segment. Eventually, though, the ventricles contract and they begin to repolarize. This is going to start from the epicardium, from the outside in to the endocardium. And so what we see is what was positive is now slowly changing back to negative, going in this direction. So we have negative charge moving upwards towards our negative electrode. In other words, we have a negative movement of charge away from our positive viewing point, which creates an upward deflection, which we see as the T wave. T wave represents ventricular repolarization. So, in a normal heartbeat, the SA node sets the rhythm, it sets the rate, sorry. It fires. Before it fires, all of the tissue in the ventricles, all the tissue in the atria is negatively charged. That's negative 90 millivolts resting membrane potential. Don't worry about that. It's negatively charged. Again, we're looking at lead 2. So we're looking at the heart like this, going this way. Negative. There's no change right now. We're at a baseline. All of a sudden, the SA node fires, and this positive action potential flows through the atria, turning it from negative to positive in this direction, towards the AV node, towards our positive viewing angle. Positive towards positive, upward deflection. This leads to our P wave. Then all of the atria are positive, and that signal is sitting in the AV node. The AV node holds on to that signal before it allows it to go through to the ventricles. That causes the PQ segment. right? This return to baseline and no change. All of a sudden, AV node lets go and lets that thing rip straight down the left and right bundle branch, and then around through the Purkinje fibers. It's going to cause the ventricles to contract from outside to in, apex to the base, to the top of the ventricles. So we have all this positive flow, right? Because these were negative before the AV node released its action potential, and they're going to change to positive in the direction like that, kind of over to the left, because the left ventricle, it's a lot more tissue than the right, so there's more tissue for electrical activity to actually be changing in, and so the kind of vector of charge, it's skewed to the left a bit. Don't worry about it. But it's moving towards our positive. So positive towards positive gives us this giant upward deflection. So QRS complex is ventricular depolarization. Every time the tissue depolarizes, it needs to repolarize. So what follows it? Well, first, everything is positive in here because it's depolarized. The atria are back to negative. The ventricles contract and they repolarize. And that creates our T wave right here. Ventricular repolarization. It will always be, it should always be, it's not always, but it should be taller than our P wave because there's more tissue that's repolarizing. But anyways, atrial depolarization, ventricular depolarization, and with every ventricular depolarization, there should be ventricular repolarization. Some time occurs, the SA node fires again, right here. It gets through, causes that P wave, atrial depolarization, gets through the AV node, ventricular depolarization. Ventriculars are contracting, nothing's changing in terms of electricity. Ooh, ventricles repolarize, and we see that again with the T wave, and on and on and on, 60 to 100 times per minute. So now we kind of understand what these waves are. Let's talk about their timing. Okay, the timing is really important. So on an ECG strip, you have the large boxes and the small boxes. This is a terrible picture. But you have these large boxes with small boxes inside of them. The horizontal line is going to represent time, vertical is going to represent amplitude, and that had to do with how strong the electricity, the change in electricity, how much is happening. The more that we see, the more that's happening, the taller our wave will be, or the deeper our wave will be, whichever way it's going. What's most important is time, and that's going to be on the horizontal axis. So one large box is going to contain 5 small boxes in it, both this way and this way, so 25 total. But one large box represents 0.2 seconds. So 0.2 seconds. One small box. There's 5 small boxes in a large box. 0.2 divided by 5, 0.04. So 0.04 seconds. Five large boxes represent 1 whole second. Okay? So that's good to know. Okay, now what about all of these waveforms? What is the normal timing we should see? Really important ones to know. PR interval. PR interval is the first very important one to know. PR interval starts here at the start of the P wave and begins right here at the beginning of the R wave of the QRS complex. The R wave is just the big upward deflection. So beginning of P wave to beginning of R wave is PR interval. This should normally be 3 to 5 small boxes, or at the most, it should be 1 large box. So that would be three to 5 small boxes, 0.04 seconds per small box, 0.12 to 0.2 seconds. PR interval, 3 to 5 small boxes, 0.12 to 0.2 seconds. What the hell does that even mean? Why is that important? PR interval tells you how long does it take for the impulse generated in normal sinus rhythm, generated from the sinoatrial node. Remember, that impulse starts here. It goes through the atria, causing atrial depolarization. It then gets to the AV node, and the AV node holds on to that thing super tight and doesn't let it go yet. That's what causes our PQ segment, our flat line. And then it says, get out of here. It goes to the ventricles, and it starts our ventricular depolarization, our QRS complex. PR interval tells you how long it takes for that signal to get to the atria, depolarize the atria, get to the AV node, and then for the AV node to let it go to the ventricles. So PR interval, starting with P wave, how long does it take for our signal to get through the atria and depolarize them, get to the AV node, and then for the AV node to release it down to the ventricles, starting our QRS complex. That is PR interval. It's very important. 3 to 5 small boxes, or 0.12 to 0.2 seconds, that is normal. And the PR interval should not change. It should not get longer. It shouldn't get smaller. That's not good. So that's what we'll be looking at later, is we want to be looking for consistent PR interval in the normal time frame that we expect it. What else? Next important one is QRS complex. QRS complex, the beginning of the QRS complex to the end of QRS complex and the beginning of the ST segment. So that is how long does it take for our signal to get through the ventricles, depolarize them all. That's all that's measuring. QRS complex should take between 0.04 and 0.12 seconds, 1 to 3 small boxes. QRS complex. Start of depolarization, end of depolarization, return to isoelectric or baseline when we now have no change in the heart electrical activity. So, again, signal going through the ventricles, causing them all to depolarize completely. That is what we're measuring here. 1 to 3 small boxes, 0.04 to 0.12 seconds. Extremely important. I'm going to talk about it a lot. Okay. And then for the last one, actually, for now we'll just talk about PR interval and QRS complex. The other important ones would be QT interval, and then ST segment, but just for now, that's not that important for the arrhythmias we'll be talking about. So PR interval is the time it takes for our signal that hopefully originated from the SA node to get through the atria, cause them to completely depolarize, the signal to get to the AV node, and then for the AV node to release it to the ventricles. That is our PR interval. And then our QRS complex. How long does it take for the ventricles to depolarize completely? Again, in small boxes in seconds. Okay. Let's see. Okay, we understand what's happening during the cardiac cycle in the heart. We understand where that signal is originating, where it's going through, why it stops and where it stops, and we know what that should look like in normal sinus rhythm on our second lead. We know what times we really want to be looking out for, PR interval, QRS complex. Now let's talk about a really good systematic way to look at a ECG, particularly when we're just looking at one lead. Usually that's lead 2. The steps change if you have the entire picture, the entire strip, all 12 leads, but we're not going to do that today. So we're just going to do, when we're looking at one strip, when we have one lead, usually lead 2, how do we systematically read what we are seeing in order to understand what's going on in the patient's heart, right? So it's a 5-step process that can become 6 or 7 steps depending on what we're seeing. Step 1, rate. First thing you do, figure out, is this heart rate bradycardic, less than 60? Is it normal? Is it tachycardic, above 100? There are 3 ways you can do it. There's multiple, there's more than 3, but there's 3 general ways you want to do it. When you're looking at an ECG strip, right, you have a bunch of large boxes. They all have small boxes in them. Depending on if you have the strip printed out or not, there will actually be little ticks like that on top. This is not an accurate representation of how many large boxes are between each of those ticks, but what you'll see is you'll see these ticks. Each tick, the time between 1 tick and 2 ticks is 3 seconds. That should be 15 large boxes, which make up 3 seconds. 0.2 seconds per large box, 5 large boxes, 1 second, times 3, 15. So you just look for those ticks, you find 1, and then you'll have another one. You then have 6 seconds between these 3 ticks. And what you do is you count the QRS complexes in between that 6 seconds. If you have a QRS complex that goes like this, where the tick actually falls in the middle of it, it doesn't count. The entire QRS complex has to fall within those 6 seconds for it to be counted. So you take QRS complexes times, so whatever number of QRS complexes you have in 6 seconds, you multiply that by 10 to get 60 seconds or 1 minute, and that equals a rough estimate of heart rate. That's number one. Number two is you can take imagine there's big boxes, small boxes here, but what you do is you look at the distance between these two QRS complexes. And remember earlier, this upward deflection is actually the R part of the QRS complex. So when you're measuring between one QRS1 and the other, it's called an R to R interval. So you look at that R to R interval, you count how many large boxes there are, and then you take 300 divided by number of large boxes between R to R interval. So number of large boxes between the R to R interval. Other way to say it, number of large boxes between one QRS complex and the next. 300 divided by the number of those large boxes, rough estimate of heart rate. The other way to do it, taking that same QRS complex to QRS complex or R to R interval, look at the small boxes. Of course, the smaller you get, the more accurate you get, right? Smaller boxes, 1,500 divided by the number of small boxes equals heart rate. So just for an example, I don't have a problem. Let's say the number of large boxes was 3. So 300 divided by 3, the number of large boxes between our R to R, in our R to R interval, or between our QRS complex to QRS complex, is 3 large boxes. 300 divided by 3, 100 beats per minute. 1,500, so let's say it was 3 large boxes. That's 15 small boxes. Again, 1,500 divided by 15 small boxes, 100 beats per minute. So you have 3 different methods that you can do it. If you really want to do it, you can count out the individual box, how many large boxes until you get 6 seconds worth of large boxes, and then count QRS complexes, but they should have those 3-second little tallies to let you know. So rate, very first thing, again, consistency. Do go in the same order every time. That's how you improve. First thing you're going to do is you're going to check rate. Is it bradycardic? Is it normal? Is it tachycardic? Number 2. I think I spelled that right. Rhythm. Number 2 is rhythm. Again, I'm going to go through this many times when we look at the individual strips, so it's not perfect, but rhythm is when you look at your QRS complexes or your P waves. So you can either measure P waves Rhythm can be measured by looking at the P waves and measuring the distance between each P waves, and is it consistently the same distance? So P to P interval. So looking at P. So looking at your P to P interval is one way to do it. maybe you don't have P waves on your rhythm. So you could do your QRS complex to QRS complex to QRS complex. Again, just like we talked about here, it would be the R to R interval. So if you look at this rhythm, and again, there's no boxes, you can't really measure it, but just a rough idea. Does it look regular rhythm or irregular rhythm? If you look at these P waves, you see that, okay, well, look at this one. It gets a little bit shorter, and then it kind of goes back, but it's still not quite the same. Look at the R to R interval. Look at these QRS complexes. Okay, we got this distance, then it gets shorter and back to normal. So this would be an irregular rhythm. The time between each ventricular depolarization is not consistent. Okay, or you could look at it this way. The time between each atrial depolarization is not consistent. It should be consistent. So first we have rate. What's our heart rate? Second, what's our rhythm? Do we have a consistent amount of time between each atrial contraction, each P wave? Do we have a consistent amount of time between each ventricular contraction, each QRS? You can have P waves and you can have QRS complexes on your ECG, and the P waves can be consistent, but the QRS complexes are not consistent rhythm, or vice versa. Or you don't have P waves, you only have QRS complexes. So it's important to measure rhythm, and it's important to look at both the rhythm of the atrial contractions and the ventricular. Even if you have both, you still sometimes want to look, because some arrhythmias, you'll see changes in the timing of one, but not the timing of the other. So rate, rhythm. Next, I like to look at my P waves and my QRS complexes. I don't know the wrong color. I call this the P QRS ratio. Number 3, P to QRS complex ratio. Very simple. Do I have a ventricular depolarization? Do I have a QRS complex that follows every P wave, every atrial contraction? In a normal heart, right? SA node fires, sends it through the atria, they contract, it gets to the AV node. AV node holds it on for a second so that the atria can finish contracting, push the rest of the blood into the ventricles. AV node lets it go. It goes down the interventricular septum through the right and left bundle branch, wraps around and through the Purkinje fibers, goes all through the ventricles. They depolarize. That is normal. Every atrial contraction, there should be a following QRS complex, a ventricular depolarization, ventricular contraction. So, P to QRS complex, in normal rhythm, it should be 1-to-1. Every P wave, every atrial contraction, every atrial depolarization should be followed by a QRS complex. And again, P wave, QRS complex, P wave, QRS complex, P wave, QRS complex. Very important, okay? If there's no P wave, but there's a QRS complex, our QRS complex might not be originating, the signal that's initiating our QRS complex probably is not originating in the atria. Or sometimes there's a P wave and we can't see it because the rate is so fast that there's not enough time for the machine to draw out that P wave. It gets buried in the T wave or the QRS complex, okay? So it's very important that we visualize, is there a P wave for every QRS complex? Rate, rhythm, P to QRS ratio. Number 4. We talked about it earlier, PR interval. So we figured out, hey, we have a P wave that then is followed by a QRS complex every time. But now I want to know, how long is it taking for our signal to depolarize the atria, reach the AV node, and then get sent to the ventricles and depolarize them. And that is our PR interval. Remember, what did we say it was? 3 to 5 small boxes, or it is 0.12 to 0.2 seconds. You know what? Shit, I better check it myself. I don't even, let's see. Let's make sure I know that. Yeah. So it should take 0.12 seconds or 120 milliseconds to 0.2 seconds or 200 milliseconds for our signal coming from the SA node to make it through the atria, depolarize them, get to the AV node, sit there, and then get sent down to the ventricles and begin the depolarization of the ventricles. So it's this right here to this. Very important. It should be consistent and in the normal range. That's number 4. We check PR intervals next. Last thing we do, unless there are other circumstances that mean we should look for some other things. Number 5 is going to be QRS complex. Okay. We want to know how long is it taking for depolarization to spread through the entire ventricles. It should be very quick. Okay, the Purkinje fibers are extremely fast conductive tissue. It should not take longer than 0.12 seconds or 3 boxes, okay? And it should be 0.04, somewhere between 0.04 to 0.12, but if you remember any number, it's 0.12 or less. Actually, don't even worry about looking at the lower number because it's not going to get below that. It should be less than 3 small boxes or less than 0.12 seconds. So before you even look at an ECG, you want to know everything we've talked about so far. Okay, refresh about the conduction system in the heart and why that produces the picture we see looking at lead 2, looking at normal sinus rhythm. Then we want to make sure we understand what we're looking at in an ECG in terms of timing. Our big box is 0.2 seconds, our small box is 0.04. And then we have our 5 steps. First, always rate, okay? Then rhythm. Do we have a same timing between each atrial contraction to the next one? Do we have the same timing between each ventricular, I said contraction again, atrial depolarization? Do we have the same time between the start of our ventricular depolarizations? It should be consistent. It should be regular rhythm. If it's not consistently the same amount of time, it's irregular. P to QRS ratio. Every time our SA node fires and it depolarizes our atria, it creates a P wave. That then should get to the AV node and get through the AV node to the ventricles, depolarizing them, creating our QRS complex. Every P wave should have a QRS following it. In every QRS should have a P wave before it in normal sinus rhythm. So that should be 1-to-1. Fourth, now we saw our P waves, they're there. That's, of course, okay, so 2.5, make sure you have a P wave. P waves are there, and make sure there's 1 before every QRS complex. PR interval. Okay, starting at the P wave, the beginning of the P wave to the beginning of the QRS, how long is it taking? How long is it taking for that signal to get through our atria and depolarize them to our AV node and through the AV node? It should take 0.12 or 0.2 seconds to do that. 3 to 5 small boxes, and that should consistently be that way. It should not get smaller or longer. Lastly, our QRS complex. How long does it take for our action potential to go through our entire ventricular myocardium and depolarize both the ventricles? It should be very quickly. Narrow is what it's referred to. Narrow QRS is normal. Less than 3 small boxes, less than 0.12 seconds for that to occur. Okay, so now we have our 5 steps. Before we look at specific ECGs, I think it's really important that we discuss what abnormalities look like and what do they mean. And if it doesn't make sense when we do it on the board here, hopefully it makes a lot more sense when I reiterate and kind of go through some of these things as we're looking at different rhythms. Okay, so simplest one is rate, right? Normal. Let me get rid of this. Okay, again, my goal, this video or videos, I don't know how long this is going to be in or how many videos I'll have to split it to. I don't want to teach you what a certain rhythm looks like. I want to teach you when you see an ECG strip that you can go through it systematically, look at what you see, identify what you see, what's normal, what's not normal, understand why it looks the way it looks when it's normal, why it looks the way it looks when it's abnormal, and what abnormal things mean in terms of what's going on in the heart, and then being able to understand the arrhythmia, not based on just what you memorized in terms of what atrial fibrillation looks like, okay? Because it's really way more important because arrhythmias change. There are so many variabilities in terms of what the ECG will look like. Patient size. Are they pregnant? Are they moving around? Are the ECG leads, electrodes placed in the right place? Was hair removed before they were placed? Was enough gel placed? Were they cleaned properly? Electrolyte imbalances, just what's it called? Noise, again, from movement. They're leaned over a certain way. The heart is now being pushed a little, let's say they're lying left lateral and the heart's being now closer to the sternal wall, the ribs. That'll make things look a little different. Everyone's heart is different, right? So it's really important to be able to not just memorize one picture, but to be able to understand any picture you're looking at, okay? So again, before we get into the different rhythms and really talk through them, let's talk a little bit about what some abnormal findings would be and what does that mean. So we'll start with rate, right? So rate can be, that's the easiest one. So normal rate from the sinus atrial node is 60 to 100. Bradycardia, less than 60. Okay, bradycardia, SA node, maybe it's electrolytes, maybe it's the fact that they're sleeping, maybe it is certain medications that were given, maybe they're in extremely good cardiovascular shape, and so their sinoatrial node is firing at a much slower rate than normal because it doesn't need to, or because it's something's going on that is causing it to do that. So we have a less than 60 beats per minute. And then we have tachycardia. If I can spell it right. Stressed, aroused, running, okay, medications, hormones, nervousness, hypovolemia, a lot of reasons that we could be tachycardic, okay, above 100 beats per minute. As long as that tachycardia is originating, we're talking about sinus heart rate, sinus bradycardia, sinus tachycardia. Sinus meaning that this heartbeat, this rhythm is coming from the sinus node. That impulse is coming from the sinoatrial node. That's important, okay? So normal SA, bradycardia from the sinoatrial node, less than 60. Tachycardia from the sinoatrial node characterized as above 100. Rhythm. We'll get to that when we look at ECGs. PQRS ratio. SA node, AV node. Every time that SA node fires, it depolarizes the atria. Then it gets to the AV node, it holds it. The AV node then fires, setting to the ventricles. Therefore, P wave should then be followed by QRS every time. Why? When would we not see that? Okay. If we have atrial fibrillation, atrial flutter, we may have an issue where we are seeing multiple P waves or many pseudo P waves. They're not really P waves, talking about atrial fibrillation, because they're not really coordinated to create a P wave, right? It's a bunch of little impulses. So we can get multiple of them for every QRS complex, because let's say atrial fibrillation, we have a bunch of impulses coming from around the atria, creating these very weak contractions because it's not a coordinated contraction. So let's say 5 of those happen, and then 1 of them is strong enough to actually get to the AV node, and then cause the AV node to send it down to the ventricles, depolarize, QRS complex. So we just had 5 P waves, and then finally 1 was strong enough to get to the AV node through it into the ventricles. So 5 to 1. Better example is atrial flutter. We have basically, it is a circuit, a re-entry circuit of electricity in the atria that's going like this. And it's going circular, and every time it circles around, it's depolarizing the atria and depolarizing towards the AV node. But the AV node can only send so many signals down to the ventricles. If the signals come to the AV node too quickly, it is in a refractory period. It's resetting from the last impulse, and it can't take another one, so it blocks it. So in atrial flutter, as an example, you can have this cycle of impulses causing the atria to depolarize coordinatedly, but depolarize multiple times for each time that one of those impulses is allowed to go through the AV node into the ventricles. Because the other ones that are coming through are getting blocked by the AV node because it says, I'm tired, I'm still resetting from the last impulse. So you can see 2 to 1 or 3 to 1. 2 P waves for every QRS, 3 P waves for every QRS. Or maybe our QRS, our depolarization of the ventricles, maybe the signal that is causing that depolarization is no longer coming from the SA node. Maybe it's coming from down here in the left ventricle. And so what we see is there will be no P wave in front of that QRS complex because the atria did not contract did not depolarize in order to cause that ventricular depolarization. It all happened down here in the ventricles. That would be a PVC. Or it can happen in the AV node or the bundle of His, otherwise called the junction of the heart. It's called a PJC, premature junctional contraction. If it starts right here, it starts in the bundle of His or right in the AV node, you probably won't see a P wave because it starts here and it goes down this way, depolarizes the ventricles at the very same time that it depolarizes the atria. And so it'll actually be hidden in the QRS complex. Another example of where you might not see a P wave with a QRS complex. Maybe you have the SA node firing normally, but the AV node has got medication, an injury, ischemia, whatever it is, the AV node is not functioning correctly and it's blocking signals. And let's use a very extreme example as a 3rd degree AV block, where at this point, the AV node is completely blocked to the point that, okay, I take that back. Let's use a 2nd degree, type 2 2nd degree AV block. Don't worry about it right now, but the point is, the SA node is firing, the AV node is letting it through, causing the ventricles to fire, but something in the AV node goes wrong, and that SA node fires, the AV node blocks it. Ventricle, nothing. And then the AV node lets it through. And then nothing. And then again. So what would we see? We'd see a P wave, but no QRS. Another example where you might see 1 to 0. Next, PR interval. Why does that look like I spelled it wrong? I don't know. What did we say PR interval was? Normal PR interval, 3 to 5 small boxes, 0.12 to 0.2 seconds. I swear I'm spelling that wrong. What the hell? Why do things look weird when they actually aren't? No, it's correct. Okay, whatever. What did we say PR interval was? It is the time PR interval measures the time that it takes for a signal to be released from the SA node go through the atria, depolarizing the atria, reach the AV node. The AV node holds onto it for 0.1 seconds, causing our return to baseline. We're going to stay there for a second, and then the AV node sends that motherfucker down, causing our QRS complex. PR interval is measuring that time that it takes for our signal to get through the atria and then through the AV node and initiate depolarization. Extremely important when you're looking at things like anything happening above the ventricles, issues there. PR interval is important. So what might that look like? I'm going to give you an example of a short PR interval and a long PR interval. So, no, I keep going over there. So this was in our normal sinus rhythm. This PR interval, you can abbreviate it PRI. .12 to 0.2 seconds is how long it took for this signal to get through the atria, through the AV node, and initiate ventricular depolarization. Let's look at an example when it's short. Atrial tachycardia, which we will look at in depth later, it is a type of supraventricular tachycardia. But atrial tachycardia specifically is when the tissue that is setting the beat is not the SA node. there is another patch of tissue in the atria that have taken over at a much faster rate than the SA node, which is preventing the SA node from taking the job back from it. That's why it's tachycardic almost always. It should be always tachycardic. But let's say we have a piece of the atria right here that has taken over. And now it's firing like SA node, it can't capture anymore. It's done. It's still firing, but or maybe it's dead, maybe it's not. For atrial tachycardia, there is a tissue in the atria that has taken over from the SA node and is setting the beat at a very high rate. What happens if it's down here? Well, let's take a look. And this often is the case. So now it's starting here, and it's still going all throughout the atria, but we're just going to make it simple. It's got to go to the AV node. Well, look how much shorter that distance is to the AV node. And then the AV node will send it down to the ventricles. So take a look at this. Our PR and P interval. Our P wave will also look different. We'll talk about that in a second, but for now, just focus on the PR interval. So look at that. Our P wave starts here. Well, this might be, instead of 0.12, we might see 0.08. We might see 2 boxes from that start of the P wave to the start of the QRS complex. So that PR interval, the time it takes to get from this atrial tissue creating the impulse to the AV node down to the ventricles has shortened just by virtue of shortening the distance from this impulse generator to the AV node. So this is an example of where PR interval is very important, because in this case, we see that normally PR interval should be this. That tells us that that gives us an idea that it's coming from the SA node. But when we see something like this, again, we'll talk about the P wave later, but most importantly, a shortened PR interval, that gives us an idea that maybe this impulse that's generating our heartbeat is not coming from the top right, from the SA node, but it's coming from atrial tissue down right next to the AV node. And so the time it takes for that signal to get to the AV node and down to the ventricles has shortened. It's very important. What about a lengthened PRI interval? So let's take AV blocks. Let me just double check for a second. So we'll use a first-degree AV block. This is a arrhythmia where the AV node is holding on to that impulse for too long, but it's doing it consistently, and it's still allowing it to get through to the ventricles. Again, we'll talk about that later, but for our case, the SA node is still firing normally, sending a signal through the atria to the AV node, but the AV node is holding on to it for too long. It's holding too long before it sends it down to the ventricles. And so what you might see So in this case, you'll see lengthening of the PR interval, because at least, again, this case, in first degree AV block, when the SA node fires normally, it goes through the atria, both the atria normally. See, we see this normal P wave, but then the AV node is the one that's got an issue. and so it's holding on for too long for whatever reason. And we see this lengthening of the PQ segment before it finally lets go, and we get ventricular depolarization. And so our PR interval is now longer than what it should be, normal, let's say 0.3 seconds. And so when it lengthens, that tells us, okay, the time between ventricular depolarization, the time between atrial depolarization, getting to the AV node and being released to the ventricles to start ventricular depolarization is now longer. So somewhere in that chain of events, something is being blocked. And most often it's the AV node. Sometimes it's the SA node, but that will manifest in another area, not the PR interval. So usually it's the AV node. Something is holding up our signal from getting through. And that could be getting longer and longer. So PR interval, we're looking, is it normal and is it consistent? Because it may start normal, but then you look at each heartbeat and it gets longer and longer and longer. It may start normal and it gets shorter. It may always be short, consistently the same, but short, consistently the same, but long. That's why it's very important. Lastly, QRS complex. Kind of arguably the most important one, especially because of what it usually means is happening. So QRS complex, shape is what we're looking, shape, time, whatever you want to say. So normally, less than 0.12 seconds. Why is this the case? So QRS complex, normally 0.12 or less. It's called narrow. Normal is narrow. So in our normal heartbeat, let's say it's starting at the SA node, it comes through the AV node, goes through the bundle of His, the right and left bundle branches, wraps around, and then goes into the ventricular cardiomyocytes via Purkinje fibers. That is the conductive pathway that it takes. Conductive pathway is made up of conductive cardiomyocytes, pacemaker cells. They are made to transmit the signal extremely fast. Contractile cardiomyocytes, the ones that actually squeeze and cause muscle contraction, are not made to transmit a signal, a impulse, an action potential very quickly. So let me say that again. So nodal tissue, pacemaker cells, conductive cardiomyocytes, conductive cells, they're all referring to the same thing. The cells that make up the conductive pathway, the SA node, the pathway to the AV node, the bundle of His, the bundle branches, the Purkinje fibers. This, if you want to call it nodal, pacemaker, or conductive cells, they have high impulse transmission. They are made to conduct that action potential extremely quickly. So if our impulse is traveling through the conductive system, through the bundle of His, bundle branches, Purkinje fibers, and then into the ventricles and causing them to depolarize, it should occur very quickly. And so when you have in 0.12 seconds or less, so when you have a impulse that gets to the ventricles through the conductive system, the normal way it should get there, it is going to go very quickly. It is going to create a narrow QRS complex, a fast depolarization. not a perfect timing, but let's say it's now 0.24 seconds. It's doubled. It's wide. That's not normal. But why is it wide? This is a pretty crappy drawing of a PVC, a premature ventricular contraction. What that means is that this heartbeat, this depolarization of the ventricles has started from some sort of pocket of tissue in the ventricle. And it spreads through the ventricle from contractile cardiomyocytes, contractile heart cell, muscle cell, whatever the heck you want to call it, from one to the next, and not using the normal conductive system pathway, those nodal pacemaker conductive cells that are really good at pushing that impulse fast. Instead, in the case like this, and in almost every case where your signal starts in the ventricles, it is being transmitted from cell to cell, not from the fast conductive system. So when you have this signal that's going cell to cell to cell through the ventricles, it takes time because those cells, those contractile cells, are not made for it. And so you get this slow depolarization, this wide. It takes a lot of time. It's not normally like this. This is extremely important to be able to distinguish the two and to understand what this means. This wide QRS complex means that our signal is originating from the ventricles. If it's originating anywhere above the ventricles, anywhere above here, the bundle of His, the AV node, the atria, the SA node, it is going to follow the normal conductive system. For the most part, there are some exceptions, but we're not going to talk about them really, I don't think. So just get in your head, if the signal originates from above the ventricles, so if it comes from the junction made up of the bundle of His and the AV node, from the atria or from the SA node, it'll go through the normal conductive tissue, the normal conductive pathway, which is very quick to depolarize the ventricles. If it originates from anywhere below that, anywhere from these ventricles, for the most part, it is going to flow through contractile cardiomyocytes, through the just normal run-of-the-mill cells of the ventricles, which are not made for transmitting an impulse quickly. And so it's slow and wide and takes longer than 0.12 seconds. So that is why it's so important, because it gives you such a good idea of where your QRS complex, where your ventricular depolarization originated from, which is really helpful in figuring out if you've got a ventricular arrhythmia or an atrial arrhythmia. So again, rate, PQRS. What does it mean when we have multiple P waves for every one QRS? Or we have no P waves before a QRS? Or we have a P wave with no QRS? PR interval. What does it mean that PR interval is normal? What does it mean when it's short? And what does that indicate? What do we start to think about? What about when it's long? What do we think about when our PR interval has lengthened? And then QRS complex, the shape, how long it takes for it to complete. Narrow, it's the conductive system is carrying that signal and then it's going through the ventricles. If it's wide, slow depolarization is occurring because our signal has come from below this line. It has originated in the ventricles and it is slowly depolarizing the ventricles cell to cell that are not made for fast transmission.